Hello everyone. Here I will describe the pharmacology in geriatrics, elderly. We know the stages of life from neonate to super serious, and most of us must have passed from stage 1 to reaching middle age, seniors, adult or super seniors. Now life expectancy in India, according to 2022 to 2023, in females is 70.42 and in males is 67.8. There are so many factors which matter at the advancing age or in the elderly. Mobility issues, individual, personal, family, social matters, mentation, medication, multiple medications, and complexities within. For example, there are more than one disease, and that makes it very difficult for following the treatment regime. So, 5 M's of geriatrics are very important so far as pharmacotherapy is. Advancing age itself provides opportunities for greater disease burden. Cognitive impairment may be due to Alzheimer's disease, Parkinson's disease, vascular dementia or strokes, repeated strokes. Visual impairment commonly due to cataract, macular degeneration or some other retinal disorder. Frailty may because of nutritional deficiencies or cardiovascular disorders, atherosclerosis, coronary peripheral vascular disease, heart failure, diabetes and its complications, arthritis, osteoporosis, fractures, cancer, incontinence of urine or feces. All are known to occur as the age advances after 65 years of age. Multiple disorders are known to occur and self-care is also neglected. So, treatment adherence is extremely poor unless physiological changes affect the drug disposition as age advances. Here you will see that kidney function, glomerular filtration rate, cardiac output and maximum breathing capacity go on declining with age, and in a patient with 70 years of age it is almost half to one third of the adult, and these are the important caveats for making dose for drug use. So change is also in composition of body compartments. Percentage of body water is reduced. Lean body mass is also reduced. Body fat is relatively increased in males and females. Serum albumin is reduced. Kidney weight is reduced and liver blood flow is reduced. When these changes are occurring, obviously drugs are metabolized, excreted, and such a function is grossly affected in advancing. These changes actually result in changes in the half-life. It's just one example. For example, half-life of certain CNS depressants, lidocaine, anticoagulants, antibiotics double or become more than double with the advancing age because of the net changes in the functions, organs. Now, pharmacokinetic changes can be seen in the form of changes in the drug absorption, changes in distribution, changes in biotransformation, and changes in the drug excretion. Absorption becomes slower because of reduced splenic blood flow and reduced gastric acid formation. Distribution is always changed because of age-related decline in hepatic synthesis of albumin, reduced body mass, increased body fat percentage, and reduced body water. Therefore, volume of distribution changes. Reduced plasma protein binding and increased free drug may be seen because of these changes. And the drugs with narrow therapeutic windows are required to be adjusted. Thus, digoxin should less be used or smaller loading dose should be used. Biotransformation in drug metabolism also affects as the age advances. Phase 1 metabolism, particularly cytochrome oxidase system, is having less activity, whereas phase 2 metabolism is not much affected. Hepatic blood flow is reduced, therefore drugs whose metabolism or hepatic clearance is flow dependent, for example beta blocker, their dose has to be adjusted. Ability of liver to recover from toxins, for example alcohol or drug-induced toxicity, declines with ages. Therefore, drug effect is adversely affected. Excretion is an important kinetic parameter that is reduced because there is age-related decline in renal function, and it has been calculated that there is a decline of 1 ml per minute per 1.73 meter square per year after the age of 40 years. Formation of creatinine is also reduced because muscle mass reduces with the age. Therefore, serum creatinine may not actually reflect the glomerular filtration rate. And some other measures can be taken. For example, cytostatin. So, cystatin C levels are more reliable, however, they are cumbersome in measurement. Therefore, Concorde Gold formula is still applicable between 40 and 80 years of males, and 85% of the value will reflect in the pharmacodynamic changes also occur because of several changes in the physiological mechanisms. Blunted homeostatic compensatory mechanism in elderly, rise in cardiac output during moderate exercise is due to increase in stroke volume and not heart rate. In young, both occur during exercise. Average blood pressure goes up with age, as are changes of postural hypotension. That is, when an elderly person stands up, there is a fall more than 20 millimeter mercury, and that leads to fall. And this will be exaggerated when a direct vasodilator drug is used. The average 2-hour postprandial blood glucose level increases by 1 milligram per cent for each year above the age of 50. Therefore, postprandial glucose level may actually be little higher in normal or diabetic patients. Temperature regulation is impaired and hypothermia is poorly tolerated by a decrease in responsiveness to beta adrenergic agonists have been found because of changes in the beta receptor sensitivity. It has been found that altered signaling, downward signaling due to beta adrenergic desensitization results in changes in the activity or density of beta receptors. There is also age-related decline in dopamine and serotonin receptor and their transporter activity. Exaggerated response is also known to occur with some certain drugs in elderly. Increased sensitivity to result in extrapyramidal reactions when neuroleptics are used, prolonged sedation and hangover when long-acting benzodiazepines are used, and greater anticholinergic effects with antipsychotics, antidepressants, antihistaminics, and antimuscarinic drugs, and paradoxical excitement with barbiturates and opiates. Elderly are more prone to adverse drug reactions and adverse drug interactions. Because of polytherapy, it has been found that 3 to 5 times more number of drugs are given to elderly as compared to younger, and they are more prone to adverse drug interactions with them. So our endeavor should be to reduce the number as possible to them. More interactions occur also because of elderly may take hidden forms of active drugs in the form of herbals, household medicines, and sometimes over-the-counter drugs. All may have active ingredients which interact with the main therapeutic drugs prescribed. Nutritional problems are there, so there is a poor compliance and treatment non-adherence leading to medication errors. Sometimes drug is not taken missed or it is taken again because therefore, precautions have to be observed when drug therapy is done for elderly. We know sedatives and hypnotics can lead to more problems, falls, ataxia, and excitation. Opioid analgesics may cause respiratory depression, and antipsychotics, antidepressants may cause problems of sedation, extrapyramidal syndrome, and anticholinergic actions. Olanzapine as antipsychotic is considered to be little safer than others, and sertraline and escitalopram are the newer antidepressants which are considered to be better for elderly patients. Nortriptyline among the conventional drugs is found to be better compared to amitriptyline and cardiovascular drugs, antihypertensive, thiazides in low doses, calcium channel blockers are better. Non-selective beta blocker and ACE inhibitors are less preferred. Direct vasodilators should never be prescribed alone. Inotropes, digoxin has narrow therapeutic window, more likely to cause cardiac arrhythmias and toxicity in the presence of hypokalemia, hypomagnesemia, hypoxemia, coronary atherosclerosis that is always present in the patient at advancing age. Therefore, should best be avoided or narrow dose adjustments is required. Antibiotics, particularly aminoglycosides, which are renally excreted, dose adjustment has to be done. In addition, beta-lactam, ciprofloxacin, nitrofurantoin, cotrimoxazole all have to be reduced in doses in the presence of declining renal function. It is very important to understand that anticoagulants like dabigatran, enoxaparin and warfarin, they are going to cause more bleeding episodes, and therefore appropriate dose adjustment or PT-INR testing should be done. Gabapentin, famotidine are also renally excreted, therefore the dose is to be. Some other drugs are non-steroidal anti-inflammatory drugs may cause GIT bleeding. They may also impair renal function, and glucocorticoids cause greater chances of osteoporosis. Anticholinergics in any form are likely to cause urinary retention and propagation of the dementia. So risk of dementia increases with anticholinergics in the form of antihistaminics, antipsychotics or other drugs, and this must be avoided. So again, diabetic control, one must not attempt tight control, because in episodes of hypoglycemia are many. Oral metformin is considered to be okay. Other have to be given very cautiously, and one may be satisfied with the modest control of diabetes. Hemoglobin around 7.5% and glycosylate hemoglobin around 7.5%. Benzodiazepines are not the first choice for insomnia, agitation, delirium. Cholinesterase should be avoided in dementia because they are cholinergic drugs and they will cause GIT problems and diarrhea. And sometimes elderly have leaking because there was a constipation which they have ignored, and there is an anal leak. And we should never give anti-motility drugs like loperamide because that will worsen symptoms. Bowel wash is the best treatment for pseudo diarrhea. Behavioral and psychological symptoms, antipsychotics may be given, but there is a reason to use olanzapine than conventional ones because of risk of EPS and sedation. BS criteria for appropriate drug use in elderly have been given by American Geriatric Society, and this is a very nice document containing 5 tables: list of drugs to be avoided, list of drugs which are potentially inappropriate in certain diseases in elderly, list of inappropriate drug interactions in elderly, list of drugs to be used with caution in elderly, and list of drugs whose dose is to be adjusted in renal disease. And one can access this document online. The reference is given herewith, and the last revision has been done in 2020. So general conditions: evaluate geriatric patients thoroughly to identify condition that could benefit from non-drug treatment and that could benefit from drug treatment, adversely affect by drug treatment. All these categories have to be found out. And what will be the influence of the efficacy of the drug treatment? They have to be evaluated beforehand. Now there are medical conditions which can often be managed without drugs, and this is also an important caveat. Now whatever drug is prescribed, we must know the altered pharmacodynamics and pharmacokinetics in elderly. Considering clinical state of the patient, renal, hepatic function, hydration, that could actually affect the overall efficacy and safety of the drug. For drugs in their active metabolites which are removed by kidney, dose adjustments have to be done. And I will reiterate again, Concroft gold formula is still considered safer as it tends to underestimate creatinine clearance. So it avoids excessive drug dose. Patient have to be instructed, communication has to be done regarding appropriate drug use. Do not stop medicines even when symptoms are improving. If there is a medication error, a caregiver sibling has to be involved who will provide adequate help. Liquid medicines are difficult to measure because bottle has to be opened and teaspoon full is to be filled. So it is better to use dosing syringe in elderly. Saliva formation is reduced. Therefore, a big size tablet or a sticky capsule is found to be problemsome, that is troublesome. Child food containers are often elder proof and therefore patients with hand joint arthritis will not be able to open them. Drug labels in small prints will not be useful to the patients because of cataract, declining vision, and they are not legible to read. Therefore, a caregiver sibling has to be involved in all these activities in order to avoid misuse, underuse, or overuse. Now, how to increase the adherence? As told earlier, caregiver must be involved. Drug regime should be simple, less number of drugs, clear instructions, using same dose schedule for all drugs wherever it is possible, maybe once or twice daily, timing the doses in conjunction with daily routine, paying attention to impaired cognitive function, diminished hearing, poor vision while instructions are given or labels are provided, instructing relatives and caregivers on the details of the regime to be continued, and enlisting other health professionals, home aides, pharmacists, to help them in compliance because they may need help quite often. Making sure that the older patient can get a pharmacist or vice versa and can afford prescriptions and can open the container easily, and using compliance aids, and that is drug calendars, pill boxes, which are easy for the elderly to open or operate, can be given, and careful medication education and patient family education at the time of every hospital discharge, and keeping updated the medical records of the elderly and reviewing them at each visit. All these caveats will increase the adherence and reduce the risk of use. Thank you very much. Further reading can be done on this reference. Good day.